Once again, thanks, Rob, for inviting me to this to give this grand rounds. This is the topic that I enjoy discussing because of its importance, and it's even more important now that it's ever been because of what you guys have heard in the media, and we'll cover some of this in this talk. So physicians have tried to have recognized pain as a medical problem a few centuries back, and it has not always been the case. Part of it goes back to even religious teaching, to where for a longest time to endure pain was considered to be a stoic, an experience that could have you become a better person, which has not always been the case. And in around 1500s, we start seeing first reports of physicians using opium to treat pain. Not until 1680, Thomas Sydenham, who was, of course, an English father of medicine, they called him English Hippocrates, he came up with the opium tincture, which really was a mixture of opium and wine, but it was very effective in treating pain. Thank you, Rudy. We got your spot right here. Yeah, fashionably laid. And of course, since then, there were invention of the sedative gases that allowed for painless surgery, which also has a very interesting history behind it. When the sedative gases, anesthetic gases were invented, not all of the physicians were on board, similar to some of our pain management pathways that we'll describe later. The physicians actually thought that it was unethical to operate on an unconscious person. So because that person didn't know what was happening to their body. So it's very interesting how our perspective changes as the time goes on. Of course, invention of the syringe with the hollow needle allowed for different routes of administration, which were a lot quicker, which was also important. And another important milestone was, well, of course, morphine, which is an opiate, not the opioid, was isolated in 1804. But 1898, Bayer, so Bayer Pharmaceuticals, they're still around, they were able to acetylate morphine. And a very interesting thing happened by acetylating morphine. They came up with a substance called heroin, which was also effective when taken orally to control pain medicine. And that's what they meant to invent. And of course, some of the best inventions sometimes get used in inappropriate ways. At the same time, they were able to acetylate salicylic acid as well. So that was aspirin. So that turned out really good for everybody. Heroin, not so much. So very interestingly, when the opiates and opioids were starting to being used, and they really came into the industrial production of those substances in late 1800s, it was lauded as a cure for all. Really, they used it for direct sedative effects, and they also found out about the number of side effects that they could use to their advantage. So antitussive, anti-diarrhea, so the side effect of constipation, they figure out they're going to try to treat diarrhea. Sleepless baby, fussy baby, sure, give them some opiates, that will help. And, what are the other things? So excessive secretions, colds, cardiac disease, yellow fever, sure, yeah, you can use it all. Not only you can use it all, you can buy it. This was the ad from the Sears catalog. You can just buy it on the catalog. So it's completely unregulated. You can buy the paregoric, which of course was morphine, or laudanum, which is a tincture of opium. So 20th century rolls in, and all of a sudden there is a report that's starting come out as far as the addiction and dependency problems. Also, there were reports of young males using heroin to snort it instead of taking orally. And what they figured out that if, because of the rapid absorption, if you intake opioid by snorting or intravenous or subcutaneous use, you can actually get high out of it. So they figured out that the quicker the absorption of the opioid into your body, the better high you're going to get. And at this point, this was completely unregulated. So anybody could sell or make opioid. It was not even taxed appropriately. So 1914, Harrison Narcotics Tax Act, which is very important, still used up to this date, really effectively outlawed recreational use of narcotics. It was not initially meant to be that. Initially, it was meant to be just a tax law. So the government said, well, wow, this is a lot of people buying opioids. We need to tax it similar to alcohol or tobacco, because at that point it was completely unregulated. And then they took a step further, and by the time the bill was passed, they outlawed the recreational use of opioids, which was actually very important, because at that point there were a number of physicians that would prescribe those medications to their patients, to the ones that already were dependent and required the opioids to kind of continue with their addiction. So several physicians were actually penalized. Some of them went to jail for prescribing the opioids for the patients who had what they deemed to be incorrect indications. 1929 Committee on Drug Addiction, so another federal committee that was created to battle the rising problems that were related to dependence and addiction. So also very interestingly, so once those federal regulations were put forth, they were so effective that it really curbed the problem for a long period of time. So we went through the World War II. We've had a lot of vets, several wars. We had problems, people coming in with pain, but the pain was dealt with. There were non-opioid drugs that were invented, the regional blocks, the surgical anesthesia. There were a number of techniques that were being developed. In late 1980s, early 1990s, American Pain Society wanted to bring more awareness to pain control. So there was more awareness about patients' anatomy, more awareness about patients' needs. So they came up with this idea of fifth vital sign. So for most of you guys, or for a lot of you who were trained around that period of time, you remember how important that fifth vital sign was. I remember walking in every room required to have a sign, something similar to this, on the door. Everybody required to document some type of smiley face or some type of pain scale. And this was very, very important. So American Pain Society had a great idea. They said, we need to raise awareness, bring this to our attention. And then, of course, the Joint Commission comes in and says, wow, this is a great idea. Well, we're going to give you a new pain management standard, because it's all about standards. And by the way, if you don't abide by the standard, we're not gonna rate your hospital well. And then hospitals say, well, if they're gonna rate us, we're gonna rate every individual physician. So if physicians don't do what they're supposed to do, their ratings are gonna go down. And then of course CMS jumps on board, and they're just like, oh wow, well if those doctors and hospitals are not doing what they're supposed to do, taking care of our patients, we're gonna decrease their reimbursements. So if like a lot of good beginnings, this is spun completely out of control. And of course, the lawsuits are starting to pop up. There was this Sentinel lawsuit in 2001 to where the patient's family sued a physician because they thought there was a documentation of the patient having pain score of 7 out of 10 when he was discharged home, and they thought that physicians did not do their due diligence. And legal court agreed. So they said that the physicians had a legal duty to relieve suffering of the patient, and if the pain was not adequately controlled, they committed a malpractice. So it resulted in settlement, and this suit was used as an index suit for a lot of other suits. So this was, a lot of changes were happening. A lot of those changes were not based on any type of clinical science. And number of myths that were propagated for, probably about 20 years. So opioids are the best and most effective treatment of acute and chronic pain. So opioids have been around, or opiates have been around for centuries. In 60s, 70s, most of the narcotics were used to treat cancer pain. There's really were not a lot of indications, but all of a sudden, people thought, and part of it was some of the deceptive practices that we're going to talk about that were kind of pushed upon us. If it works for cancer pain, well, it has to work for post-surgical pain. It can work for acute pain. It can work for chronic pain, like a back pain. And it really what was happening is that a lot of narcotics were rebranded as analgesics. So, and that really appeals and mitigates the negativity bias, because most of us, if we were told that, hey, we're going to give you narcotic, you can say, well, narcotics sounds really bad. You know, I might get addicted to it. But if I'm going to tell you that, you know what, we'll give you some pain medicine to just, you know, to help with the pain because we want to take care of your needs, that sounds a lot better. So a lot of it was the biases, our cognitive biases that we internally have in ourselves. Another cognitive bias is that prescribing higher doses will give you a better pain control. Well, as this is true, bigger is better. You know, that's something that appeals to us and makes us feel right. But it really wasn't right. It's not, you know, it's only creates problems, particularly, you know, more problems with abuse and certainly problems with overdose that we're going to talk about. Another interesting statement that was propagated that there was, you know, there was a lot of semi-synthetic and synthetic opioids that were come out around the same time. And what pharmaceutical companies were telling us is, you know, those are new drugs. You know, opium was really bad. Opium is narcotic. That's, you know, we wouldn't use opium. But there is a lack of evidence that those new drugs create addiction. Well, lack of evidence is not the same thing as evidence of having lack of addiction. And a lot of people were not savvy enough to recognize it. Well, why was it happening? Is, you know, we're all very smart. You know, the health industry is very smart. How did it all happen? Well, aggressive marketing campaigns and really deceiving practices by pharmaceutical company was the driving force behind a lot of those myths. You know, there were pain experts, so a lot of physicians at the time, and that was legal at that time, they would send into extravagant vacations, they had extravagant presence, and they were educated on the pain principles by pharmaceutical companies, experts from pharmaceutical companies, and all of a sudden you had physicians who were leaders in their fields that would obtain this, you know, deceiving information, and then they would propagate it down. There were, you know, those physicians were in leadership roles at many committees, many national societies. Free coupons were given to the patients, so for the opioids for the first month, 2 months of use, which is absolutely terrible, obviously, with dependence potential that those medications had. And, of course, expanded indications. You know, the pharmaceutical companies were behind all of this rebranding of the opioids, and, you know, all of a sudden you could use them pretty much for any indication. So we dialed back 100 years back. So what was happening 100 years back to where we had opioids as was cure for all, now all of a sudden we expanding indications because we have not seen the problem. So lack of scientific evidence, that was a problem. And of course, lack of sufficient oversight. So all of this was happening. And there was no governing body at the time that kept an eye on this and helped us to decide why can we have some pain control guidelines. There was nobody that helped us do that. And of course, here's the reason why all of this was happening. So 2012, this is after we've realized you know, how much trouble we were in. We were still, opioid sales just in the United States grossed $11 billion. So this was huge billion-dollar industry. You know, Purdue Pharma, so they're behind, they're the main the drug maker for OxyContin, the poster child of problems that we've had in early 2000s. Their earnings in 2017 were $35 billion. So once you put the money behind it, that explains a lot of effort that was put forth. So 1990s to 2010, the prescribing of opioids quadrupled. You can see right here, around 2012, this is where there was concerted efforts to try to decrease the use of opioids. And even with 17% reduction, we were still 3 times more than where we were in 1999. So that is quite a substantial number of opioids that was prescribed to our patients. And of course, during this entire time, we have not seen decline in pain reporting. So increase of use of opioids did not result in decrease of pain. What had happened, however, is opioid death quadrupled. So as the opioid prescription quadrupled from 1999 to 2007, the death related to overdose quadrupled as well. Now, what were the reasons for the opioid death? They have changed over the years. It started out, most of the deaths were related to prescription opioids, and then it's changed to heroin, and now it is the synthetic opioids that is a problem. So, we have this concerted efforts. Everybody or a lot of physicians now are aware of the problem that we've been having, really epidemic proportions problem. However, decline in the opioid prescribing right now really had not resulted in a decline in overall death related to the opioids as general. Well, why is that? Why is, we saw on the graph that as the opioid prescriptions quadrupled, the overdose deaths quadrupled. Why is that now that we are prescribing less and we've had a pretty good effort and pretty good results at decreasing the number of opioid pills that we're prescribing, why do we not see the decrease in rate of overdoses that were related to the opioids? Well, there's a couple of reasons why it could be happening. Many of you are familiar with this addiction cascade. There's always initial use, the first exposure. Did we create a first exposure drug for a lot of those patients? And then once they got along in their cascade, now things spun out of control? Probably. We can see the increased risk of death that are related to fentanyl and other opioids that are synthetic opioids that are not prescribed by physician, but a lot of those patients at one point, and usually first exposure, did have a legal prescription that was given to them. And, the gateway drug, it's another theory that people will argue. And it's very interesting now with, legalization of marijuana. People get very sensitive about this gateway drugs. The gateway drugs are even real. And of course, the argument that they use is they say, well, alcohol is considered to be a gateway drug. By age of 18, we have 60% of people that were exposed to alcohol. We don't have 60% of our population being addicted. So it cannot be. So this theory is not right. Well, this is not a valid argument. A lot of people try to, fit their argument to their needs or to their agendas that they want to propagate, similar to what pharmaceutical companies were doing in 1990s. There is a vulnerable population. There are patients that are genetically predisposed to addiction, particularly to opioid addiction. And of course, there are people that have mental problems, anxiety, depression, post-traumatic stress disorder. So we have a vulnerable population, which we don't have very good tools of how to identify. We have no way to tell who's going to get addicted to opioid, and all it takes is one exposure. And who'll be able to go along and have their normal life. And that was one of the problems with this lack of evidence. Without studying it, our population with the scientific methods, that's what the pharmaceutical companies were doing. They were saying, well, look at this. Most of the people who prescribe opioids, they do just fine. And because they do fine, then it means that there's no evidence that opioids are addictive. So it's something that they make it sound plausible, but of course it's not correct. It's a fallacy. Opioid is a valuable analgesic. We do know that. And it's an important drug in management of several conditions. However, it is a narcotic. So it needs to be made and explained very clearly that it's a narcotic with a significant potential for abuse and dependence. There's a number of other side effects that it has that also need to be explained to the patient, and also physicians need to realize that this is really not that great of a drug. It does have significant problems despite being a valuable analgesic. So beyond the first exposure, activating this addiction cascade, this is a very interesting graph that I like, because this one kind of graphed out number of days of non-medical use of opioids, and you can see those 30 days or more a year, and of course this group is the highest risk for abuse and overdose. Where do they get their drugs from? So we think that people who use opioids for recreational use, that they all go to drug dealers and they have their, they go buy it on the street or somewhere. Well, look at this. This is given by a friend or a relative for free. This one is stolen from a friend or relative. This one is bought from a friend or relative. Most of those people get those drugs from their friends or relatives, which means that we're not prescribing those opioids. Even if we prescribe it for the right indications, we're not prescribing correctly. We're creating a pool of meds that are available to go on back in society, and we're really contributing to the problem. What is the physician role with all this? obviously responsible prescribing. So opioids, we still, our role, our obligation as a physician is to the patient. We need to be able to relieve patients' pain. We cannot, this is not one of those things to where, well, we're just going to go back into 1400s and going to say, you know what, tough it out. This is not it. Our obligation is to the patient, but we have to use those opioids appropriately for appropriate duration, appropriate doses, correct indications, and of course, this is a legal change, recent legal change, but it's also, morally, we have to explain to the patient what are the risks that are involved with that. If they're going to be prescribed the opioid, are you going to be, just like as we explain and give informed consent for surgical procedures, we need to explain that those are the problems. This may be the drug that you need, but those are the problems that you could encounter. And of course, the tools. We have to have the tools. Our obligation to the patient is to control their pain. If we cannot use opioids, and that's what we've been using for 20, 30 years, we have to have something else as a substitution, something else to be able to control their discomfort and pain. So from 1999 to 2017, almost 220,000 people died in the United States alone as related to overdose from opioids. Why is this important? Well, this is a lot of people. So not until November 2016, so we've known about those problems for at least a decade, probably longer. And not until 2016, Surgeon General came out and said, you know what, it's getting really bad. The opioid crisis is a bigger problem than cancer. So that's the Surgeon General that declared it in 2006. President Trump, so the White House, Office of the Press Secretary, opioid use is a nationwide crisis. Following this, the Department of Health and Human Services, they looked at things, they looked at other governing bodies, and they said, wow, this is really bad. We have people, 90 to 100 people die every day just from the opioid overdose. This is really a public health emergency. CDC, so all of those governing bodies there, all of a sudden, this data has been available to us for years, but now it's all came to a head and everybody came into realization this is a real problem. So, they called the opioid use an epidemic. So it was epidemic proportions. How do we fare? So we have a nationwide crisis in the United States due to the opioid abuse, opioid dependence, and opioid overdose. In Nebraska, we fared pretty well. And it's, some people say, well, we're relatively shielded. But you know what? This map didn't look like that 10 years ago. So you could see this wave that was coming from East Coast and West Coast and how it's closing in. Iowa predated Nebraska problems by probably a year or two. So that has been a real issue for them. And it really is becoming an issue for the Nebraska as well. So if you look at the numbers, U.S. drug overdose death rate in 2017 was 21.7. How do we fare in Nebraska? Well, we're doing better. It's 9.8, but you can see we going up just like the rest of the United States. So even though we're still 3 times better than the average of the United States, we're almost 3 times higher than we were in 2004. So it is a real issue. It is a real problem. So as we were recognizing this problem, the number of legislative bills was introduced in 2018. Virtually every single one of them was approved in some form or another as amendments to a different bill, but they were approved, and that created of course, new legal changes, which are important to be followed by all of the medical professionals. So one of the important change is 3 hours out of our continual medical education needs to be dedicated to the opioid prescribing. Half hour out of those.
Internal disruption standby, medical gas monitoring system move, continue normal emergency response procedures.
Okay, it seems to be an everyday thing. I don't know. Sounds like a crying wolf kind of deal. Every day we have a medical disruption, so it's terrible. So half an hour of it needs to be dedicated to our prescribing, to our monitoring program. So prescription drug monitoring program, which of course records everybody's not just opioid use, but benzodiazepines and other scheduled medications. So as a disclosure, and by the way, I do not have any financial interests. That's my disclosure. I don't own stocks in any of the drugs that we're going to be talking about, including oxycodone. But there is a disclosure. So this CME will qualify as your requirement, at least 1 hour out of those 3 hours that's related to opioid prescribing. Another change, and many of you have seen that now because of the efforts that we've had here at Methodist, you're not allowed to prescribe more than a 7-day supply for the new acute condition for somebody less than 18 years of age. This is important because we know that the higher MME, morphine milligram equivalent of the prescription that we give to the patients, the high rate of abuse and the high rate of overdose. So this is very important. And we are now required to give counseling to the patient prior to first or initial prescription and the third prescription, as far as the possibilities of addiction and overdose, to get a full disclosure for our patients. PDMP, so in Nebraska, PDMP is not, legally cannot be integrated in EMR quite yet. It's a crazy, old law that we still have in place, but there's a new bill, hopefully it's going to be passed either this year or next year, that will allow us for easier ability to look at this PDMP. I think PDMP is a great program because why would you not want to know if your patient is doctor shopping, or if your patient is overusing the opioids, or it just gives you more information. However, right now it's not possible. We have to, as a physicians, if we want to check PDMP, we have to go to NEHI. So we have to go in, and this is several steps to go in and log in and double check. And a lot of physicians, that just stays outside of the workflow, so it's very difficult for them to do that. But this is going to be something that's very important because the CMS already passed a regulation saying that that for all of the Medicare patients, you will be required to check PDMP prior to prescribing opioids in 2021. So it's Medicare. That's a lot of our cancer patients. So this is something that's hopefully will happen to where the Cerner will be able to look through and give us those warnings, saying that this patient has had the prescription filled by his medical doctor, by the 2 ER visits over the last 2 weeks, and now they're coming in with a broken arm, and maybe they have a broken arm, but there may be something else going on as well. So what have we been doing here at Methodist, to try to help? We're seeing nationwide crisis. We're seeing the state efforts. And we have a opioid guardianship project that most of us or a lot of us have been part of. This has been a concentrated effort to curb the opioid use on our health system level. We have champions from various specialties, champions from administration that get together and try to guide our health system in this environment. And of course, numerous multimodal analgesia projects that we have had here 2015 and prior. So how successful have we been here over the last year with our opioid guardianship? Well, over the last year, we've had a reduction by 740,000 opioid pills that we've reduced over the last year that's been prescribed to our patients. So this is, that's staggering. It's not quite 1 million, but that's pretty impressive.
Is that just for inpatients or inpatients and outpatients?
This is for the entire health system, and that's also will include Jenny Ed and Women's Hospital. So inpatient, outpatient. We also have seen a 22% decrease in those 90+ MME. So every drug is assigned the conversion factor based on its potency. And when multiplied by this factor and multiplied by the number of pills, that will give you what the prescription, how many MMEs that prescription was. 90+ we know creates a high risk for overdose. 50+ creates a high risk for addiction. So those ones are tracked separately. So and everything now is tracked. So all of you guys, whatever you prescribe is being tracked. We can look back and we know who the physicians that consistently prescribe this. So we actually, so all of this information is available, and right now there's no legal repercussions but it will be, because we're already seeing that there's a legislature that the bill has been passed for patients who are 18 years of younger. So there's going to be more laws to come. And of course, one of the roles of our opioid guardianship has been to try to keep up with both national and state regulatory requirements. The other interesting fact was, so this was actually how much our Methodist Health Plan has spent on opioids, and we actually have seen, so amongst our employees, people who are insured by our health plan, we actually have seen a $50,000 reduction. So, how is our head and neck team? This is, the title of this talk is obviously the pain management in head and neck patients, and I'm a head and neck surgeon, so this is something that we can do as our group and try to show our experience to the rest of the system. How do we contribute to the efforts that have been led by Methodists? Well, 2015, we started to implement the multimodal non-opioid analgesia protocol. This, mind you, predates all of those national warnings. So we were ahead of time, really a year or two before all of the warnings came out. We were looking at our patients, and we were finding that the opioid use really was not benefiting them. As a matter of fact, a lot of our patients, their reason for staying inpatient after the potential outpatient surgical procedures was the use of opioids. We'd go in and we would try to find out what was the reason why the patient stayed overnight versus being able to be discharged home. And what we find out is, they're dizzy. They cannot get out of the bed. They're nauseated and vomiting, so they're staying overnight because of they're not able to tolerate PO and they need IV hydration. And we're finding out that those were all the side effects. So beyond dependence and abuse, those are potent medications that have significant side effects. And we really did not see an improvement in their pain scores. So we were trying to figure out what tools can we use to still mitigate the pain of our patients, because once again, we as a physicians want to make sure that our patients are not suffering, but then at the same time to curb the use of those drugs that were making our patients sick. So by 2017, we had a 51% reduction in the use of opioid drugs for those outpatient surgeries. So 2016, this was our first official study that we as a head and neck team were able to publish. It analyzed the patient satisfaction. We looked at the pain scores, and we found that 87% of our patients who were enrolled into this multimodal analgesia protocol were either satisfied or highly satisfied with their pain management protocol. So this was very important, and this, at first we wanted, not to harm our patients. We needed to establish that our new protocols, non-opioid-based protocols, are effective. Once we found out that they were effective, the next study that followed it a year after looked to see how are we doing adopting those protocols. And as you can see, the Tylenol was the easiest. Everybody's like, well, we'll give Tylenol to the patient. That's fine. That makes sense. Gabapentin, a little bit harder. NSAID was the hardest one to implement because a lot of physicians were worried about side effects. And, my patients still will receive, the call the night before on their instructions. Stop use of all the NSAIDs. Stop use of aspirin before your surgery. They even tell them to stop vitamin E, which, I think it's crazy, or fish oil. Crazy, and then I call them and I tell them, no, you take an NSAID. As a matter of fact, I'm going to give you an NSAID the day before, on the day of the surgery, because it really has not proven to have any risk of hematomas. But they still, up until this day, when our patients get a call, they're told, don't use NSAID, or your surgery may get canceled. So we can see that our compliance has improved significantly. So by 2017, close to 92% and now we're even better. You can see the slope, but close to 90% of our patients, maybe a little bit more, were receiving some type of non-opioid multimodal analgesia. And you can see what was happening to the outpatient opioid prescriptions as the multimodal protocol was implemented. So this NSAIDs, so that's where the problem is. And up until this day, we have physicians within our health system who are vehemently opposed to use of NSAIDs before the surgery, and they cite the risk of bleeding. This is the main problem, because in the past there was some literature contradicting evidence of whether bleeding can happen if somebody uses opioids before or after the surgery. And one of the studies that was being cited is the study that looked at the tonsillectomy patients, and even though they didn't see increased rate of bleeding, but they saw possibly saw the increase of significant bleeding events. Now we've had meta-analysis that have been done and directed studies that have looked at everything: orthopedic surgery, colorectal surgery, GYN surgery. There is a couple months ago, there is a large meta-analysis that was published in plastic surgery patients. So plastics have been another specialty that have been reluctant at prescribing the multimodal analgesia because of the risks are so high of hematoma. They don't want to take this risk. Well, we don't see any high rate of bleeding. So NSAIDs are completely safe. In all of our studies that we've looked in the past, we work around the airway. We remove very vascular organs. So if anybody were to have the risk of bleeding, you would think those would be our patients. But we did not see increased risk of bleeding in either one of the studies. Furthermore, as a quality improvement, we've now been looking back at our flap patients. So at around July of 2017, because we're seeing such a success of our multimodal analgesia management, that we've introduced the protocol to every single head and neck patient. So we went from selected group of people who were having thyroid surgery to group of people that were having outpatient surgery, to now we extended this protocol to the most complex patients that were having the most complex surgeries. And review of the data, so for the last year and a half, we've compared, we have not had increased rate of bleeding, so it's pretty high because those are high-risk patients. But you can see that before implementation of the multimodal analgesia, this is after implementation. This was before. So if anything, it was we had less bleeding episodes, but this is not statistically significant. So exactly the same rate of bleeding, total flap loss. So this was after implementation of the multimodal analgesia. We did not have increase in complications that were resulted into the flap problems or wound complications. So we now know that I really cannot hold an honest argument with people who say, well, I'm going to do a tonsillectomy, but I'm not going to use the NSAID before or after because I think there's increased rate of bleeding. Well, really, literature does not substantiate that, and we do. We remove tonsils through the radical tonsillectomy procedure, which is significantly bigger deal, and we still don't see any problems. So what are the tools? What is that multimodal analgesia? Different people have tried different things. In our hands, this is what works best. Local analgesia, so longer acting preoperative injection or preoperative injection at all. A lot of people have not used that in the past. There is cold therapy. We now uniformly use cold therapy on most of our patients. That has been very effective. There's other commercial products that are available that can help with this local analgesia. They're really probably applicable for other surgical sites and head and neck, less so. Acetaminophen is the important part of our multimodal analgesia. Very interestingly, I was trying to figure out how it works. How does it relieve pain? I don't think it's very clear yet. It still remains undefined, probably related something to the COX-2 effects, but we found out that 1,000 milligram dose was the most effective when it can be given. Of course, 4 grams is a day max for most of the patients, and this is the problem. So we'll mention it again. Part of the strategy that was implemented by those deceptive practices by pharmaceutical companies was to link the Tylenol to the opioid. So those combination drugs, they're actually terrible because once you take that, you cannot take Tylenol. So if you need additional pain relief, you kind of stuck. You're going to have to give more opioids. So you have to disengage. So if you have to give an opioid, it has to be an opioid. It has to be a non-combo drug because this way patient can still be on their maintenance of Tylenol and ibuprofen separately, and they are able to receive opioid as needed if they needed it. There is if you look at the use of Vicodin or hydrocodone, 99% of the prescriptions in the world are prescribed and used in the United States. Why is that? Is because hydrocodone, they don't manufacture hydrocodone without Tylenol. So it's a combo drug, so it's a terrible, terrible, terrible drug. It was, meant to prevent you from using Tylenol separately. So COX-2 inhibitors, all of those have been tried and used successfully. Toradol, mostly in kids. Ibuprofen, we use it successfully postoperatively in most of our patients. Meloxicam and celecoxib, both are really good. I actually like celecoxib better for the shorter surgeries because of when the time of the duration and also the time of the onset of the peak effect. But we just going with meloxicam right now because of easy and convenience. Those are the doses that we use. Most of them, most of those you guys already accustomed to and you've seen. So this is safe, and that has been for now several years. This is our typical postoperative protocol. So you can see that oxycodone is still part of the protocol. So if somebody has a terrible pain that's not controlled by our multimodal analgesia, they can still use the oxycodone, but it's not linked to the Tylenol. It can be given at the smaller doses. There's no need to prescribe a bigger doses or give a longer duration. So the goal of our analgesia is to give those tools to the physicians so the physicians still treat the patient, still relieve the suffering, but at the same time to decrease the use of opioids because of all of the side effects that we've discussed. Some are references, and I'm open to questions. Go ahead, Rob.
In the study that we're doing right now,
Yes.
Have we noticed a difference? Are you breaking it down, the difference between flap types too, like if we're doing a bone reconstruction versus just soft tissue?
It is possible to do. We have the data. I'm not sure that it's, we can see if it's going to become a factor. This would be easy to do as a part of the multivariate analysis. I think we're going to see the reduction. We know that it's been safe. That's the most important part. I think if we use it as a conglomerate of the data, as long as the data has the same heterogeneity, so we don't have, after implementation, all of the bone flaps or soft tissue flaps. But it's something that would be interesting to look at. I don't know if we're going to have the numbers. I understand what you're saying. Some of the flaps, just the skin reconstruction flaps, that they probably don't hurt any more than your regular skin excision, and they may require no opioids at all. And I think that's the point. I think once we establish the safety of our protocol, see, right now we really do not know. We think they're safe, and we have a preliminary data that says it is safe, but there's really no data nationwide to say that this is okay to do. We really have a equipoise. We know it's the right thing to do, and we know it is safe, but we have not proven it yet. So that's why the study that Ricky is doing right now with data collection, we are very close to getting the statistics analysis, and once we get that, it needs to be published right away because this is very, very important, really clinical practice changing data.
One comment and one question. This is more for the trainees. There is another big problem linked to the opioid crisis, and that's hepatitis C. So the largest group of individuals in the United States are young people in their 40s who are using opioids, heroin, and so on. That is the fastest growing group. And as you know, hepatitis C is actually curable, but it's also very expensive. So that's something that we need to also consider in this turmoil of crisis. And then the question for you, what do you think about acupuncture? Would that even work?
Oh, absolutely, yeah. So it's and I have so this was the talk as far as using the opioids and our protocols, but absolutely, I'm a firm believer. So part of it, and it wasn't one of the slides. So part of the management of pain, and not a small part, is management of anxiety. And that is very important. So our opioid, our enhanced recovery protocol, it starts preoperatively in the office when we discuss with the patient what's going to happen to them, and we discuss with the patient how we're going to use our protocol. See, this multimodal analgesia protocols, they have not been as successful at other institutions because the people try to read an article and they say, okay, I'm going to give them a gabapentin, I'm going to give NSAID to whomever, I'm going to give a Tylenol, and we're just going to give a run. But they don't invest time into training of the nurses. They don't invest time into training of the physicians. And if you do not counsel your patient appropriately, if you do not set your expectations appropriately, that's where you run into trouble. So we've had papers that have been published saying, as of even last year, saying, oh, look at us, we've been so successful. We decreased the opioid use on thyroid patients from 100% to 40%. Well, that's crazy because we've shown in our data that less than 2% of patients actually require an opioid treatment after majority of the outpatient head neck surgeries. So what happens? They're not managing expectations correctly, and they're not comfortable with managing patient anxiety. Some of our early failures were to where patients were so anxious, they were so afraid that if they were not going to receive that opioid drug, that the pain was not that great. But there was everybody told them that if you're going to wait and the pain is going to become really bad, you won't be able to treat it. So the patient would call us and say, hey, the pain is not really bad, but I know it's going to get really bad. Or they may say, you know what, I need it right now because I'm worried about it. And if you explain to them and you tell them, I got your back, we'll take care of your pain. This strategy is very effective. And we got it. We got you. And if it is, we're going to have something that's going to be available to you. So it's anxiety management. So a lot of it is a mental state. So managing expectations, managing anxiety. And we know that as you modulate, so the pain is not just what physically goes in from your surgery or whatever happens. It's modulated significantly. We all know by our central processing. We know how soldiers have their arm cut off or leg cut off, and they won't complain of the pain because it's modulated through the central processing. But then at the same time, you get ingrown toenail, and it just you're laying out, and it's like that's the worst thing in the world. So whatever you can do to modulate the pain processing, whether it's acupuncture, whether it's aromatherapy, whether it's an auditory stimulus, this is all tremendously helpful. I've been thinking, playing with the idea. I was like, well, why don't we get a small little infuser in recovery, in a patient's room, on every single room on the 5th floor for our recovery patients. It's definitely not going to hurt. The risks are very low, but if it puts them in a more relaxed, better state of mind, why not? I mean, we know this, for the kids, they have the little smelly, scratchy thing. You give them smell, it helps out with the nausea, helps out with the pain. Why not have it available for our adult patients? Anything we can do. Acupuncture, for sure. It's whether it works based on physiological basis or whether it works based on psychological basis. Absolutely. All of those are very important. Yeah. I agree with you 100%. And by the way, thank you for saying that 40-year-olds are young people. You said young people who are in their 40s. I really appreciate you saying it. This is great. Yeah. All right, Vic. Yeah.
I just want to add, in case there's anyone in the room, I haven't said this to you before, that nonsteroidals are a great part of the rehab protocol in older people. I don't worry about the bleeding mess.
Yeah. Creatinine. You worry about kidneys. Yeah.
I worry about hearts and blood pressure
Yeah.
and kidneys.
Yeah.
And so going with the 400 milligram dose in older patients is much safer than.
So, as you guys, thank you for mentioning this. So, we do have some safeguards. So, with multimodal analgesia, and I don't know, it may have been there on the slide. So, there's 2 drugs, the NSAIDs and gabapentin, both actually affect older people differently. So, somebody over the age of 75, we do not use gabapentin at all. Somebody over the age of 70, we only use 100 milligram dose. So our 300 adult dose gradually increases just with their age. That's even if they have a completely normal renal and hepatic function. And NSAIDs, of course, we have a creatinine clearance stop. So some of the patients, so you saw that with the NSAIDs, some of the patients did not receive it despite our intention to give it to them. And that was the hard block that we placed. So somebody with decreased renal clearance will not receive it at all. The other fail-safe that we have in our protocol is all of our preoperative doses, they're really a half of the prescribed dose. So our meloxicam, we do not give a 50 milligram dose, they get 7.5 milligram. So everything has been decreased to make it safer. We want to give the smallest possible dose that could be used for vast majority of our patients, which a lot of them are elderly patients. So absolutely, that's a very good point. Any other questions?
Thank you, Dr. Melissa.
Yeah, thank you guys for attending.